All right. Welcome, everybody, to SEVA VentRounds. Today is February 21st, 2023. And in our talk today, we're going to discuss overassistance and see a couple of cases that have been shared with us. Today, I will be your only host, Eduardo Mireles, and Rob Chatburn and Ari Garnero are in a ARC event. So it's just me. So we discussed particulars of ventilator modes. There's no endorsement of any particular mode, manufacturer, or company. Whatever we say, it's in this case my opinion. It does not represent Cleveland Clinic, and these are my disclosures, which we will not discuss during today's event. Keep your microphone muted, but if you want to speak up, the best way is to put it on the chat. And if you have questions, just unmute yourself and connect to the event, and we're happy to interact with you. Now, sorry, I'm going to skip this. A part that I want you to be aware is that we now are offering respiratory therapy CRCEs, and so here's the QR code. I'll put it again at the end of this event, and you just have to enter your name in the chat to verify that you came and saw us, and use the QR code on the right and the link on the chat to complete the evaluation. And obviously, the evaluation must be completed within 1 hour of completion of the event. So let's talk a little bit about work shifting. And we discussed this last time, but work shifting is when the P-vent and PMOS are active together, and on some portion of the total work is done by the ventilator and some by the patient. So if the patient is completely passive, so meaning paralyzed, there is no work shifting, or the whole work is being done by the patient. But whenever the patient starts doing some effort, work shifting will occur, and the patient will start doing some of the work, and the ventilator will react depending on the type of mode that they are on. And so there's three types of interaction that the ventilator modes can have with in the presence of PMOS. And the first one is this one, in which is a descending relationship. But the more PMOS, the less P-vent. And the classic examples for that is volume control, or the adaptive modes like pressure control, CMB, so PRVC, or volume support. There's a linear relationship, which is, or continuous relationship, in which the ventilator will continue to deliver the same ventilator pressure, regardless of the pressure the muscle generates. So in this case, the patient can be doing a lot of effort, and the ventilator will continue to deliver the same pressure. And those are the classic examples are pressure control and pressure support. And finally, there is the third type of relationship, which is the proportional, meaning that as the patient does more effort, the ventilator delivers more pressure. And the classic examples for this are the servo training, as the servo ventilators, or servo targeting schemes, which is PAV, NAVA, and tube compensation, do all of those. So a key fact or understanding here is marrying the concept of work shifting with the concept of assistance. So whenever you have pressure above the baseline, there's an amount of assistance that is occurring from the ventilator on the patient. And so let's start by just the term assistance. And it's whenever there's PMOS and P-vent are present and they're above the baseline. And so here you have an example about volume control, and you can see here that even though the pressure gets deformed in the presence of PMOS and the presence of muscle effort, they're still above the baseline, which means that the ventilator is delivering more flow than the patient needs, which means that the patient is being assisted. The same here you see in pressure control. There's evidence of PMOS on the flow waveform, and you can see that the pressure is above the baseline. And although it deforms somewhat as a manifestation of the PMOS, the pressure is above, so there's assistance. And the last one is the servo, in which you can see that as the patient does more effort, this is the electrical activity of the diaphragm, the pressure delivered is higher as more there is. And so this is assistance. And Depending on the clinical situation, it may be appropriate or not, but the fact is that the ventilator is assisting the patient. Then we have under assistance, which is what we would call severe work shifting. And in the past, they used this term called flow starvation to refer to this. But essentially what happens is that the patient is doing so much effort that the pressure drops, as you can see here, below the baseline. And under those circumstances, the patient is not getting any assistance from the ventilator. Actually, if anything, is doing work on the ventilator and creating negative pressures. And then the other term is overassistance, in which essentially what it means is that there's unintentional minimal patient effort, or PMOS. And what that means is that you gave too much support, and that quieted down the PMOS, the muscles. And here is an EDI, and you can see very small waveforms. And there's other clues over here that we're going to talk in a second, but the ventilator is delivering the tidal volume, the pressure, and an amount of tidal volume that is disproportionate to what the patient wanted. And so that has quieted down the PMOS. Alrighty, so now that I have put that out there, this is important for you to just put it into context of when we talk about overassistance, assistance, and underassistance. So again, here's the CRC for the respiratory therapy. We're very happy about that, and thank you, Ryan Kutro, for facilitating this and making it happen. So we'll start with our first case, and if you, as you remember, the goal here for in these next minutes is for you to test yourself. So I know that we have some of our fellows and respiratory therapists on the line. If you want to put in what do you think is the tag for this, so meaning what's the true name for this mode, so what's the breath control variable, the breath sequence, and the targeting scheme, then what is the load, and then if there is any patient ventilator discordance. And I will highlight this is a image that was sent to us by Troy Withacre from Missouri University Hospital, and this is a very nice example for all of us to work on. So you're walking by, you see this image, what is the tag, and if you can put it on the chat, what is the load, and then what's the PV discordance. And have no fear, the chat is invisible to everybody outside of the recording, and so this is good for us to review and talk about it. I'll give you a couple of minutes to look at it, come to terms with what is the tag, what is the load, what's the PV discordance. Alrighty, so I'll get started now that you had chance to take a look at it as you're finalizing what you're typing. So the tag, I mean, it says here pressure control. In the tag is actually is PC, so the breath control variable controlling the pressure. And so you set the inspiratory pressure. You see it here is 22 above PEEP, so this patient is getting a fair amount of support. The breath control variable, the breath sequence, sorry, is every breath that we see here is triggered by the patient. So, and we know that because it has changed here to the pink color, which tells us that the machine is recognizing that this is a patient triggered breath. And you also see this little symbol over here. That little symbol, whenever it turns on that screen on this ventilator, it tells you that this is a patient triggered breath. And then we know that this is cycled by the machine. And the reason why we know that it's cycled by the machine, not only because of the mode, but we see that the flow has reached zero at the end of the breath and it's flat, which tells us that the PMOS has, and there's no PMOS, and the breath has ended. So this is a breath that is cycle delay, if you would see it there. And so this is, all of these breaths have that, which tells me that all of them are cycled by time. So this is CMB. And the targeting scheme for pressure control is set point. So meaning you set the total pressure that the patient is going to get, the PEEP, the inspiratory time, and whatnot. This is always important because it helps me see where to look. So if I go and look at the load, I always like to see if this is elastic or resistive. And in terms of elastic, we see that the time constant is very fast. The breath reaches zero baseline as baseline in less than a second. And when you see the expiratory time there, well, there's some what seems to be effort here or some oscillations that should not be there, but it returns relatively fast to baseline. So this makes me think that this patient has elastic load. And I don't see any evidence of PMOS or very little evidence of PMOS. I see that the target, the trigger that is happening on the flow, it's a flow trigger. Barely you see, but there is some deflections that seem to be dropping the pressure just before, and I'm gonna amplify it for you so that you can see it for a second. And you can see that it does look like there's a drop in pressure just before. But after that trigger, there is actually no evidence of PMOS. So I like to look to the inspiratory limb, and you see how the exponential decay tells us that there is no evidence of PMOS. And if there was PMOS, we would expect this to be deformed up here. So it would look something like that, the waveform, which we don't see at all. So in this case, this is a passive, looks essentially passive. And that's a clue that should come into your mind, is that I don't see any evidence of PMOS throughout the inspiration, which tells me that this patient is essentially, if it's triggering, and then there's no evidence of more than that. So very minimal. And so the trigger, if I would look at it here, it looks actually normal. However, there's these little oscillations that are happening pretty often. So you see them here, approaching the baseline on each breath after that one. And this one is probably even more evident. You can see how it goes up and it goes down, goes up and it goes down. So that it's like if there was missed triggers or what we call failed triggers. So I would say that there may be failed triggers, but otherwise the trigger over here looks normal. So this is a question mark. Just by looking at this, I would say, oh, what is that that is happening there? And this is normal. And sometimes this gets solved by just putting the patient on the hand on the patient and trying to figure it out what it is. And you can see the evidence of that here. You can see how instead of decaying not exponentially, you see this little humpy that it's occurring here that tells me that there's some effort and something is causing airway deflection. During inspiration, there's some things that tell me that there's overassistance. One is that there's no evidence of PMOS, and that's something that should trigger you to think that there's overassistance. And second, the fact that there is potentially failed triggers, that should also it's another marker of overassistance. So the presence of triggering with no evidence of PMOS afterwards, and the presence of failed triggers are two clues to the presence of overassistance. In terms of cycle, again, as we said at the beginning, it seems to be late. So if you were going to correct something, you probably could correct also that. The inspiratory time is too long. So you can see all this period of time from here to here is too long. So the patient had essentially had just the lung inflated in a pause with no volume change. And you can see that there is no volume change here, no volume change, no volume change during that period of time. And then expiration, perhaps I don't see any expiratory work. It seems that there's actually inspiratory work. So I would say that it's normal. All righty. So that's what they saw. So Troy saw that. And I mean, this is very impressive, and I don't see Troy on the line, but he and the caring team suspected that something was going on because they had the rate at 15. There was all these what they thought were failed triggers, and so they decided to place in an EDI. And so you see here the electrical activity of the diaphragm was placed, and you see that they changed the PEEP to 10, they actually dropped the pressure control down from 22 to 18. And they still see this triggering that is happening now. The rate is at 14. It was 15 before. Now it's 14. So they have been adjusting the ventilator up on the PEEP, and you don't see any more. Actually, now the patient exhales and it's triggering. Now, instead of 27, it's 32. So 32 breaths per minute are being triggered with a little bit lower tidal volume. But the key finding here is the absence. There is actually, you can see that the ventilator is triggering, right? So the ventilator says that the patient is triggering. When you put the EDI in, there is nothing. It's flat, zero, nada. So this tells you that this patient is having false triggering, and that was actually causing this event. So there's no evidence of electrical activity of the diaphragm, and there is evidence of triggering. And so you can see how we were misreading this as failed, but actually what is happening is these are false triggers. So it's triggering every single breath with absence of any electrical activity of the diaphragm, which is impressive. But again, you don't see any evidence of PMOS throughout the flow because you're controlling pressure. You don't see any evidence of PMOS during inspiration or expiration. And actually on this one, you barely, if anything, see any change or any dip before in the pressure waveform, which should tell you something is happening here. So they changed the trigger from flow that was set at 2, and they changed it to a trigger of -2. And what I want you immediately, what you realize is that there's these oscillations occurring here. And I wish Troy was here to tell us what was the heart rate for this patient. But you can see now the oscillations. None of the breaths are being triggered by the ventilator. There's actually no evidence of, and the rate is 14, which is meeting the same rate that you set. And there is no evidence of electrical activity of the diaphragm. So in this case, this patient was being overventilated, so probably alkalotic from overassistance triggered by a false trigger on this patient. And these are good things. I mean, you do not need, this is important, I'm going to say it a couple of times, you do not need to place an electrical activity of the diaphragm catheter to detect this. I don't want that to be the message. Actually, the message for us is that a simple maneuver like changing the trigger or doing an end expiratory pause and letting it go and see if there's oscillations on the pressure that manifest that demonstrate the effort from the patient, which would have looked exactly what you see over here. So this patient had something, perhaps a big bradycardia with big heart oscillations that were causing those oscillations on the airway and leading to false triggering, which got solved with that. And once that it got solved, that they allowed the patient to go down to the rate of 14. Under those circumstances, you can see that now, after a while, so the patient went from here with no EDI to now still having a little bit of EDI, right here, but now triggering the ventilator with the pressure. So now the patient was actually triggering the breaths with no more false triggering and generating their own tidal volume. Still, the EDI is in the lower side, but there's evidence of activity, of muscle activity, of electrical activity to the diaphragm. So this and you can see that they later they changed the pressure and whatnot, but The key message, I think, that is that if you have had this patient, you can imagine that in the morning you come and put them on a spontaneous breathing trial, and the patient is going to fail because the patient is going to go into apnea, which is exactly what happened down here. The patient went into apnea because probably was alkalotic, like there was no tomorrow. And I mean, you don't do routine in a patient in 30% of oxygen. It would be rare for you to do an arterial blood gas, but they would fail the spontaneous breathing trial because of either apnea, which is a common cause that we see, or very weak uh, respiratory drive. So you put them on the on your usual 5/5, and the patient is generating very small tidal volumes because it's alkalotic and it just comes out of overassistance. And life occurs and you have a lot of things to do, and you put them back on pressure control, and again overassisted. The story finishes with, and there's another slide from Troy in which essentially says that the patient went on to be on a tray collar the next day after they recognized this. So this can be a good cause of failure to wean because of overassistance from the ventilator. So I'll pause there, see if there's any comments from the audience, any questions. But this, I want to thank again Troy Withacre from Missouri University Hospital for sharing this case over with us. Alrighty. In the last 7 minutes, I put this one. This is a case from our own ICU. And I think that you will recognize several features that we have put out there. So I'll leave it there for a second. This patient also is on pressure support, CPAP. And this patient has now again electrical activity monitoring. Oh, good questions, Troy. I'm going to talk about that. So the EDI was placed into this patient because we were trying to. We saw the pattern that you're seeing on top, and so we wanted to demonstrate what you're seeing now. There's a question. So as you read this waveform, there's a question from Tim asking any way of distinguishing overassistance versus an excess analgesic sedation as a cause of low PMOS. That's a great question, Tim. There's some hints that can help you here. Obviously, if you have excess analgesic sedation, this usually relates with an altered mentation, meaning that the patient will be either with an altered mental status, and so the RAS score should be lower than expected. So that's one of the features. The second, for overassistance, and we're starting to learn more about this. I think that every time I see the missed triggers, besides thinking on auto PEEP, I think on overassistance. That's a good feature, as you can see on this case too. The presence of persistent apnea on these patients after you put them, so they go out with no evidence of effort or anything, would make me think of that as a potential cause. So, but yeah, that's it may be a good question to write something about. I like it. Thank you, Tim. So let's talk about this case over here in the last minutes that we have. What is the tag? So the tag this is pressure support, but you can see that the pressure is well controlled through this, so it's PC. And this one is CSB, so actually it's triggered by the patient, each one of the breaths, sorry. But it is cycled by the patient too. So it's cycled by flow. When the flow reaches a amount of the threshold, not the threshold, the peak. So it's a percent of the peak flow delivered. And usually the ventilators are set at around either 25, 30%, and you can modify it as you wish. And so in this case, you can see that the patient, this is the peak flow, and then there is this evidence of PMOS, of effort. So the patient triggered a breath, then had another effort, and then finally reached that threshold, and it cycled over here. And the same happened on each one of these breaths. And it's set point because you set the amount of pressure support that the patient gets. So then you have what is the load, and I mean, I'm giving you a lot, obviously the EDI here, but you can see that the breath is triggered, and you have a very nice image here of what seems to be the baseline over here, the pressure, and then it drops, and then the breath triggers. So this is a breath that is triggered all the way over here, but there's these oscillations on the waveform that are sabotaging us during exhalation and during inspiration. So I really cannot see what's the load very well, because there's a lot of PMOS throughout during inspiration and during expiration. So I would not dare to, on this graph, to say what if it's elastic or resistive. And then in terms of trigger, the trigger in this case is flow. So we know that because that's where the color change is. And there's perhaps some features that tell me that there may have been activity trying to cross, but I can see the flow being crossed right here very clearly, which tells me that this patient was, I mean, it's triggering and then it's pressurizing immediately there. So I would be comfortable saying that this is the breaths that are triggered are normally, but then there is these huge deflections here that are occurring, that it seems that it's pulling in and the pressure is going down. And actually you can match those up here. This gray waveform is a representation of the EDI up here, and it's you can see that the patient is sucking or activating the muscles in. So it's activating the EDI and the pressure goes down, and then the patient exhales and the pressure goes up, and again inhales and up, and you can actually see here. So actually I'm gonna recant a little bit, and you can see the EDI actually here, how it activates, the pressure goes down, and then it triggers all the way over here. So it had activated over here. That's one of the problems when you have an EDI, which the truth is the EDI. So actually I'm gonna recant here, and these are late triggers. You can see them very clearly here, actually, late triggers. And there's a bunch of failed uh, triggers. So there's late and there's failed triggers. And whenever I see failed, again, I think of auto peep, and I think about overassistance. And the last one that I would think is whenever there's a fail, the last one would be that the flow threshold is inappropriate. That can happen. And then in inspiration, I would say this is overassistance again, another case of overassistance. And why do I say that? Is because once the breath is delivered, you can see how long it goes. So the pressure is so high, it delivers so much volume. Actually, it goes all the way to 750. It delivers so much volume that the patient is already triggered, starting to, the breath ended, and the patient wanted to start another breath, and it starts inside this one, and then it's still getting pressure from the ventilator. So we're delivering too much pressure for what the patient wants, that it's so much that it doesn't reach the threshold to cycle off the breath. And so the patient gets too much of that breath there. And then the cycle in this case was late. I mean, but remember, we always call the first one, but I would call this late. And then there is expiratory work. I don't think so. I think that what we're seeing is just the failed trigger. So I'm going to call it normal. But this is a case that we place the EDI on the patient because it had these features, and we said this patient seems to be overassisted. And so what we did was drop the pressure support on the patient, and well, actually we changed him to NAVA, and then he was matching every single breath, and we adjusted the NAVA level to it, but the patient was tachypnic. And so the natural force of the team was that every time that they would put them on lower levels of pressure support, the patient would become tachypnic, and they would say the patient is failing, but then they would over-assist the patient. And so if the patient looked like this and he didn't have the EDI, the patient, I mean, it looked, the flow waveform looked horrible, but the pressure waveform looked okay, the rate looked fantastic. But whenever we changed them to drop the pressure support to do an SBT, the patient would become tachypnic immediately. So the treatment for this weakness that the patient had, this diaphragm issue was to overassist the patient. And so it was a never ending, ended up with a tracheostomy. And so the pathway was to put them on NAVA, and then it evolved to a trach collar. So those are the cases for us today of overassistance, which is all around us, and we just have to keep our eyes open for these features that we just showed you. Again, this is the respiratory therapy CRCE. So enter your name in the chat to verify that you attended. Use a QR code on the right, and the link will take you to an evaluation to get these powerful CMEs. And then here is the, you can also, for our caregivers that are not respiratory therapists, you can get CME. And there's the SEVA webpage if you want to tweet it, share it, encourage people to join us and to send us their images. We are happy to read as many as you want. And so with this, I thank you. And for the fellows, I'll see you in G61. Thank you all. Have a great day.